To all. I'm Dr. Naveen Khede, Manager Scientific Services from Himalaya Wellness Company. Doctors, it is indeed a moment of immense pleasure to welcome all our beloved and respected doctors who are on board. On behalf of the Himalaya Wellness Company, I take this opportunity to extend my earnest regard and greeting to the eminent guest speaker, Dr. Mahendra Singh Punia sir, and all other doctors who have logged in. Though virtually, let us all together light the lamp as a sign of keeping the flames of wellness and happiness alive. Thank you. As you know, doctors, wellness in every home and happiness in every heart has been our vision since 1930. With your constant support and patronage, we have successfully completed 90 years of trust and service in this field. During these years, we have been in constant connect with our beloved doctors through various means. This is another modest attempt from our side to organize this online event with eminent guest speaker, Dr. Punia sir, on occasion of World Kidney Day to spread the awareness on kidney health. Doctors, as you know that World Kidney Day is observed on 10th of March. I'm Dr. Naveen Khede, Scientific Services from Himalaya Wellness Company. Doctors, it is indeed a moment of immense pleasure to welcome all our doctors. As you know that World Kidney Day is observed on 10th of March every year. The World Kidney Day Joint Steering Committee has declared 2022 to be the year of kidney health for all. Specifically, it calls on all of us to work to bridge the knowledge gaps to better kidney care. The 2022 campaign will focus on efforts to increase education and awareness about kidney health. Now, before moving to today's our session, today we have something surprise for you, doctors. It is nothing but some interesting poll questions. So I would request Mr. Ankit ji to please make it live, some poll questions. Doctor, there will be no right or wrong answers in that. It is just an opinion of your opinion on a different questions. Ankit ji. So doctors, here is a first poll question. As per you, what percentage of kidney stone patients end up with the renal complications? Doctors, you have 20 seconds to answer this question. Please attempt this question. There will be nothing right or wrong answer here, doctors. It is just an opinion poll. Right. So Ankit ji, can we showcase the results? Doctors, there are multiple right answers are here. This is just an opinion. Everyone is having a different opinion on the answers. So we'll show like how many percentage of, yes, you can see here that less than 5%, that is option A is been attended by 33%, 5 to 10%, 33%. Almost all three options are the equal. So A, B, and C, all the attempts are the equal percentage. Now, second question. Yeah, here is a second question. As per you, what size of kidney stones can be medically managed? Option A is only less than 5 mm, B is 5 to 10 mm, C is more than 12 mm, and D is none of above. So, doctors, I would request, please choose any of the option. Yes. So I'm sure you have attended this question. Ankit ji, can we go for the answers, results? Yes, we are waiting for the results, like how many percentage of doctors have attempted. Yeah, here only less than 5 mm answer has been choose by 14% of doctors, 5 to 10 mm by 71%. Yes, maximum of the doctors have answered like 5 to 10 mm, and more than 12 mm, it's a 14%. Now it's a last poll questions here. Third, yeah, here it is. What are the common complications you have come across while managing kidney stone? Yeah, A is infection, B kidney injury, 3 is bleeding, and D is all. Doctors, there is no right or wrong answer here, as already said by me. Like, you have to just give your opinion. This is an opinion poll only. Yes, doctors. Okay, Ankit ji, can we go for the results? We are waiting for the results. Yes. Yeah, here it is. 20% of the doctors have given the answer A, infection, and B and C is 0%, and D, yes, all above, or 80% of the doctors have answered all above. And I'm sure all these topics will be covered during the session also. We'll have a more, we'll get some more learnings and knowledge about this questions during the session by our expert, today's speaker, Dr. Punia sir. Thank you, Ankit ji. Thanks a lot. So now, doctors, it's my honor and privilege to invite our today's guest speaker, Dr. Mahendra Singh Punia sir. Dr. Punia sir has joined from Pink City, Jaipur. Warm welcome to you, sir. Dr. Punia sir has completed his MBBS from SMS Medical College, Jaipur. He did his MS from SS Medical College, Rewa. Then he did MCH Urology from SAIT GS Medical College and KM Hospital, Mumbai. Sir has a vast experience as consultant urologist at various reputed hospitals. He is working as senior consultant urology at CK Birla Hospital, Jaipur. Sir has also worked as a urologist at Capital Urology Hospital, Apollo Spectra Hospital, and SR Kala Hospital. In his 14 years of rich experience, he has conducted more than 8,000 surgeries. Sir has attended many CMEs, workshops, presented many papers and posters in different national and international conferences. His area of clinical interests are stone disease, prostatic disease, endourological, laparoscopic, laser procedures, etc. Sir is also a member of various professional forums like Urology Society of India, Jaipur Urology Society, Surgeon Society of Jaipur, etc. So thank you, Dr. Punia sir. Everyone, stay tuned. Over to you, sir.
Sir, please unmute your mic, please, sir.
Sir, please unmute your mic.
सर, जहाँ पे आपका फोटो दिख रहा है उसके साइड में 3 डॉट्स हैं, वहां पे आप क्लिक कीजिए, साइड में आपको दिख रहा होगा.
Sir, I have sent you the request to unmute yourself. You can click on that also.
Sir, screen is visible. Audio is not coming. म्यूट के ऊपर सर एक बार क्लिक करेंगे तो अनम्यूट हो जाएगा. Yes, sir.
It's audible now?
Yeah, it's audible. It's audible, sir. Please.
Good afternoon. Myself, Dr. Mahendra Singh Punia. I am Senior Consultant Urologist in CK Birla Hospital. I have done my MCS from KEM Hospital, Mumbai. Today I am telling about the complication during the management of renal stone. Mainly there are 5 types of the renal stone. Calcium oxalate stone are the most common stone that are usually present in 60 to 70% patient. Other common stone are calcium phosphate stone, steroid stone or triple phosphate stone, uric acid stone which are usually radiolucent, and cystine stone. These are the common type of stone present. And the symptom, commonly the clinical manifestation of these stone is pain and vomiting. Occasionally when stone passed into urine there may be bleeding per urethra, and when associated infection is there is fever and chills. In case of severe infection there may be septicemia, and that can be life threatening. In advanced disease, there is renal scarring and damage to the kidney that result in permanent renal damage and complete loss of function of kidney, which need removal of the kidney, nephrectomy. In such cases, then investigation. When a patient of renal stone come with symptom of pain and vomiting, we send him for the investigation like renal ultrasound. It tell about the size of stone, site of the stone, and associated hydronephrosis and any other change in the kidney that are present. Many times we are not able to detect the stone in the mid-ureter due to gaseous abdomen. In such situation, we do the plain abdominal X-ray KUB, which tell about the location of the stone in upper, lower ureter or mid-ureter. In case of radiolucent stone, we are not able to find the stone. In such cases, we do the CT KUB, which exactly tell about the stone location and size and Hounsfield unit, which tell whether we can do the lithotripsy or we will remove this stone by the laser. IVP tell about the function of the kidney, location of the stone, and what is the best procedure available for the removal of such stone. Then come the blood test. In blood test, we commonly do the kidney function test like serum creatinine and CBC. When there is infection, we do the CBC and it tell about the leukocytosis. Urine test commonly done for infection or bleeding, whether RBC is present or pus cell or lymphocyte is present. In patients who are having recurrent stone, we do the stone analysis and the metabolic evaluation of these patients to find out the cause of recurrent stone disease. So today I am telling more about the complication associated with the renal stone. The most common complication is urinary tract infection. A patient of urinary tract infection come with pain, vomiting, and fever associated with symptom of the stone disease. In urine, we send the urine analysis which tell about the RBC, WBC. In CBC, we are able to detect the total leukocyte count, whether we need to give oral antibiotic or injectable antibiotic. Serum creatinine, which tell about the involvement or damage to the kidney. How much is the serum creatinine? USG KUB, it tell about the site of stone, size of stone, and changes due to the stone, like hydronephrosis and other damage. Then, according to these symptoms, we start the antibiotic, either oral or IV antibiotic, and symptomatic treatment. After diagnosis of the stone location, size, we plan the definitive treatment once the infection subsides. Then second common complication is pyonephrosis. Pyonephrosis means presence of pus into the kidney. The presence of pus into the kidney, patient usually have flank pain, fever, and associated tenderness into flank. And these kidney need to be drained as early as possible. So we do the urine culture, blood culture, and sonography, and then drainage of the kidney. Either we do the degestenting, or if there is flank tenderness is severe, we usually do the nephrostomy placement. Nephrostomy, by placing the nephrostomy directly into the kidney, we drain the pus out, and after the drainage of the pus, we send the pus for pus culture and then plan the definitive treatment for the stone. Whether it is in the lower ureter or mid ureter, we can do the ureteroscopic removal of stone. If the stone is in upper ureter or kidney, we can do the later on PCNL. We place the PCN tube in such a location that we can do the procedure easily later on. So we can plan the PCNL also. If the stone is small or in the kidney or infection is completely subsided, the latest treatment modality is RIRS, retrograde intrarenal surgery, in which we go to the kidney per urethra from the flexible ureteroscope, identify the stone and fragment and laced the stone and completely remove the stone. Many times due to damage to the kidney is completely damaged due to pyonephrosis and long-term obstruction. In such cases, when we place the PCN tube, it drain the pus and also tell us about how much output is from that kidney. If that kidney is not functioning, we can remove that kidney from the laparoscopic or open method. This is the USG KUB report of one of our patient, which showing the hydronephrosis, gross hydronephrosis due to upper ureteric calculus. In such patient, we can place the PCN tube from the upper calyx, and later on we can use the same puncture for the removal of stone from the upper ureter. So the same we can dilate the same tract again and can easily remove the stone. This is the patient of CT scan of a patient which have gross hydronephrosis with pus, and parenchyma is very thin out. In such patient, we place the PCN tube from the middle calyx, and after placement, we wait for about 2 to 3 weeks to completely drain the pus and to know how is the kidney is functioning. And later on, we have done the renal scan of this patient, which show that kidney is not functioning, and we have done the laparoscopic nephrectomy of this patient. This is the specimen of the pyonephrotic kidney after the nephrectomy. Other unusual complication is emphysematous pyelonephritis. Emphysematous pyelonephritis is acute and severe necrotizing infection of the renal parenchyma and its surrounding tissue. In emphysematous, there is gas in the renal parenchyma collecting system or perinephric tissue. Mortality is very high in emphysematous pyelonephritis due to septic complication, but it need to be treated as early as possible with aggressive antibiotic. The classification given by Huang and Sang on the CT finding. There is in CT class 1, there is gas only in the collecting system. Class 2, there is parenchymal gas only. And class 3A, extension of gas into perinephric space, means outside the kidney but within the Girota's fascia. And class 3B is extension into the pararenal space. Class 4 is emphysematous pyelonephritis in solitary kidney or involvement of the both kidney. This is the CT image of one of our patient, which is showing the involvement of the renal parenchyma. It is not extending outside the kidney. These patients need aggressive antibiotic treatment and drainage, so kidney can be saved and life can be saved. This is the CT image of other patient, showing the right side emphysematous pyelonephritis with involvement of renal parenchyma up to the subcapsular region. There are certain prognostic factors in the emphysematous pyelonephritis. These are hypotension, thrombocytopenia, altered sensorium, and acute renal failure. These are the 4 prognostic factors which determine the course of the disease and how we will proceed to treat these patients. So the treatment of emphysematous pyelonephritis, these patients are usually diabetes and present with fever and UTI, and many times with altered sensorium also. We give the fluids and aggressive antibiotics, send urine and blood culture, CBC, and do the USG KUB region, which usually show the gas into the renal parenchyma area. CECT KUB region is the investigation of the choice. In the initial stage, if there is gas in PCS, only in the pelvic calyceal system, we give the antibiotic and drainage the system by putting the digestant. If the gas is present in the renal parenchyma or perinephric area, and I have told the prognostic factor like hypotension, acute renal failure, and thrombocytopenia. If these features are less than 2, then drainage and aggressive antibiotic is sufficient. But if there is more than 2 feature is present and patient is in septicemia, then nephrectomy is needed to save the life of these patients as early as possible. This is the specimen of one of our patients. We have done the nephrectomy. Usually we are not able, or anyone is not able to do the laparoscopic nephrectomy in these patients because the condition of these patients is very serious. Other is xanthogranulomatous pyelonephritis. It is uncommon chronic destructive granulomatous process of the renal parenchyma. The reason of this disease is long-term urinary tract obstruction and infection. Due to long-term urinary obstruction and secondary infection, these kidney responds by the destructive granulomatous process. This disease affects female more than male, and these is 3 types: focal, that involve the cortex, segmental, and the diffuse involvement of the kidney. Clinical picture of these patients is these patients present with fever, flank pain, weight loss, dysuria, flank mass, and tenderness. On investigation in CBC, there is leukocytosis and anemia. Urine analysis show pyuria, hematuria, and presence of protein in urine. Commonly associated infection is E. coli, Proteus, Klebsiella, and Pseudomonas. On radiology, initial investigation, usually we do the USG KUB region, which tell about that there is enlarged kidney and multiple hypoechoic abscess are present. There may be granuloma, dilated calyx, and there is loss of cortical tissue. CT KUB tell about the heterogeneous non-enhancing mass lesion. Non-enhancing, differentiate it from the renal cell carcinoma. These kidney are hydronephrotic kidney. There is destruction of renal parenchyma. 80% patients are associated with stone along with destruction of renal parenchyma or this disease. And this is a chronic destructive disease, so there is extrarenal extension is also present. So this is the CT image of one patient showing the beer paw deformity. There is hydronephrotic kidney and dilated calyces. This is the other CT image of other patients showing the multiple renal calculi and hydronephrosis, thinned out parenchyma. 80% patients are associated with the stone. And this is the CT image which showing the PUJ calculus extending into the inferior calyx, kidneys, hydronephrotic and dilated calyces. Treatment is nephrectomy, antibiotic and nephrectomy. And biopsy tell about that the disease is xanthogranulomatosis pyelonephritis. Then if the infection is severe, there may be septicemia. In case of septicemia, we give the broad spectrum antibiotic and find out the cause of disease and do the immediate procedure. Like if it is blocking the ureter, we can put the DJ stenting as early as possible, or USG guided nephrostomy placement in such patient because they are under septicemia, and we can do bedside nephrostomy placement. Once the patient recovered, thus on depending size of the stone, we can do the URS, PCNL, RIRS, or rarely laparoscopic or open procedure to remove or make the patient stone free. Then due to the chronic damage to the kidney or an acute damage of the kidney, there may be decreased renal failure function. There may be renal failure. In single kidney, there is ureteric stone, sudden anuria, or involvement of the both kidney. In such cases, we do the disease stenting or nephrostomy placement, and after recovering of the function, like in acute disease, after placement of disease stent, patient recover usually in 2-3 days. In chronic, we wait for 4 to 6 weeks to completely recovery of the function as much as possible, and later on we do the definitive procedure. Many times due to ignorance of the patient, or patient is asymptomatic, usually present with non-functioning or poor functioning kidney. In these non-functioning or poor functioning kidney, we remove the kidney after the renal scan, which tell about that kidney is not functioning, and it is better to go for nephrectomy. In such cases, we remove the kidney both laparoscopically and open nephrectomy. Other common complication after long-term stone is the ureteric stricture. Ureteric stricture may damage the kidney later on. So if the kidney is functioning and we are able to detect the location of ureteric stricture, we can do the balloon dilatation of stricture, like in the lower ureteric stone. On endoureterotomy, like endoscopically cut the stricture segment and put the DJ stent. In malignant disease, ureteral metal stent can be placed into ureter. If there is lower ureteric injury or lower ureteric stone, we can do the transureterostomy, or can reimplant the ureter at the second place into the same kidney, same bladder, by the ureterostomy. So the basically today I have told about the disease, renal calculus disease associated with complication. Common complication or associated are infection, which can be a simple infection, septicemia, emphysematous pyelonephritis, xanthogranulomatosis pyelonephritis. There is decreased renal function that maybe we should detect as early as possible to save the kidney, or we can do the nephrectomy or ureteric stricture. So the treatment of we should do the treatment of these disease as early as possible to save the kidney, to prevent the patient to going for hemodialysis and renal transplant, which is the last treatment or last resort to the patient which undergo the CKD, and we require treatment as early as possible for this patient. Thanks for hearing me.
Thank you very much, sir. Thanks a lot.
Okay.
Can you please stop the sharing, sir? Thank you very much, sir.
Okay, thank you.
Yes. So, doctors, I'm sure yes, doctor. So I'm sure you all have enjoyed the session, and you are eager to ask some of the questions. Sir has very nicely explained about the different conditions like pyelonephritis, different kinds of pyelonephritis, what are the treatment options are there, septicemia. Sir has also discussed about ureteric stricture, renal failure and all. And sir has very nicely given some real case studies also he discussed with some investigation reports like CT scan and all. Dr. Punia sir has also discussed about the treatment protocol for the different complicated conditions. So thank you very much, sir, for delivered such a nice lesson. Session for all the doctors. I'm sure all the doctors have learned a lot from this session, and they are eager to ask some of the questions. Already we have got some of the questions, and I request everyone to please put your questions in the chat box. We'll discuss it during the question and answer session. In between, doctors, as you all know, the session was brought to you by the Himalaya Wellness Company, the maker of Cystone 4, an exclusive formulation to manage kidney stones. So before moving to the question and answer session, let me invite my colleague, Dr. Tanuja Rana, Manager Scientific Services from the Jaipur. Yes, again, she is also from the Pink City, Jaipur. And I will request Dr. Tanuja to give a brief presentation on Cystone 4. So over to you, Dr. Tanuja. And in between, I request all the participants to please put your questions in the chat box. Thank you. Over to you, Dr. Tanuja.
Is it visible, doctor?
Yes.
Yes.
Okay. Thank you, Dr. Naveen, for the kind introduction and the opportunity. Dear doctors, greeting from Himalaya Wellness Company.
Make it presentation mode.
Just a second, it is in presentation mode. It is in presentation mode?
No, it is not.
Just a second.
Sandeep.
There is some issue actually. It is in presentation mode. I don't know why it is not showing.
Anyways, try again.
Doctor, is it?
No, it is not. Anyways, Dr. Tanuja, it is visible. You can go ahead.
Okay. So thank you, Dr. Naveen, for the kind introduction and the opportunity. Sorry for the interruption. Dear doctors, greeting from Himalaya Wellness Company. We at Himalaya are serving humanity for more than 90 years with a vision in bringing wellness in every home and happiness in every heart. On the occasion of World Kidney Day, Himalaya Wellness Company presented to you the online talk by Dr. Mahendra Singh Punia sir. Continuing this discussion, I, Dr. Tanuja Rana, would like to present how Himalaya Wellness Company is being the pioneer in the management of urolithiasis through plant-based medicine. We have a lot of stone sculptures across the globe that gives us a sense of happiness each and every time we see it. They provide us visual treat and makes us feel good. While on the other hand, you can see there are certain stones that are capable enough to ruin all the happiness and wellness out there. They can make one's life horrible, causing intense pain and discomfort. They are known as urolithiasis. So here, doctors, we are going to have a short discussion on role of plant-based medicine in urolithiasis. We, from the Himalaya Wellness Company, started this journey by launching tablet Cystone in 1943 and Serum Cystone in 2008. We continued our quest to provide effective solution. So here we came up with another product, which with a holistic approach to manage urolithiasis. Yes, this is Cystone tablet, Cystone 4 tablet, which expels the kidney stones and prevent recurrence. Tablet Cystone 4 contains the extract of extensively researched and time-tested botanicals. And this Cystone 4 tablet offers holistic approach for the management of urolithiasis. It offers actions like anti-lithiatic, lithotriptic, anti-inflammatory, and diuretic properties. Shilapushpa, the Didymocarpus pediculata, providing anti-lithiatic actions by preventing depositions, accumulation, and supersaturation. While the hydroalcoholic extract of mangishta, which is Rubia carifolia, also have anti-lithiatic action, which decreases the level of calcium, oxalate, and phosphate levels in urine and also helps in dissolving oxalate stones. The extract of Pashan Bhed, Saxifraga ligulata, has lithotriptic action, which shows potential effects on dissolving the mucin, which binds the stone particles. Nagad Musta, Cyprus caryopsis, and one tulsi, Ocimum sanctum, offers anti-inflammatory activity. Apamar, Acaranthus aspera, and Gokshura, Tribulus terrestris, exhibits diuretic actions by increasing the GFR. So these are the pharmacological actions, doctors, of tablet Cystone Fort on urolithiasis, which helps to correct the crystalloid-colloid imbalance.
Sorry to bother you, ma'am. Ma'am, we can't see your slides changing. Can you move them, please?
Slides not changing, madam.
Yes, ma'am. Now
Yeah.
Thank you.
Actually, it is in presentation mode, sir. I don't know why it is not happening in this.
It's okay, ma'am. You can continue like this.
Okay.
You can continue, Dr. Tanuja, no issues.
So, sorry for the interruption. So there are many papers which have been published in national and international journals across the globe depicting the safety and efficacy of Cystone. So here presenting the important study published in the Journal of Urology and research showcasing the safety and efficacy of Cystone Fort in the management of urolithiasis. The conclusion of the study shows there was complete expulsion of the stone in 53% patients, those having calculi of size 7 to 12 mm, and the rest of the patients showcase significant reduction of calculi size. While on the other patients who had the calculi size of 5 to 6.9 mm showcase the complete expulsion of the stone in 57% of individuals, whereas the other patient showcased a significant reduction of calculi size. In the clinical parameters like Kolke pain, abdominal pain, which are very common in urolithiasis, Cystone Fort displayed statistically significant improvement. Other parameters like hematuria, nausea, vomiting, fever and chills, etc., were also reduced significantly. So the conclusion of this study is the Cystone Fort is safe and effective in the treatment of urolithiasis with significant improvement in clinical symptoms. There was no adverse effect observed during the study duration. Another study in which safety and efficacy of Cystone Fort was compared with tamsulosin. This study was published in Medical and Surgical Urology. In this study, concluded that Cystone Fort tablet is having comparable results with the improvement of clinical parameters in urolithiasis and expulsion of kidney stones as compared to the tamsulosin group. So yes, we can say that Cystone Fort also having some additional benefits like anti-lithiatic activity, lithotriptic activity, anti-inflammatory and diuretic properties. So the indication of this Cystone Fort tablet in urolithiasis is stones up to 12 mm and crystalluria, and also helps to manage the post-lithotripsy complications. The doses of this tablet is urolithiasis, urinary stones up to 12 mm, and crystalluria in adults and children above 12 years, 2 tablets twice daily till the stone passed out or till symptoms subside. And on post-lithotripsy urolithiasis, 2 tablets twice daily for 6 weeks. So this is all from my side, doctors. At the end, I only wanted to say that the Cystone Fort helps to expel the kidney stones and prevent recurrence. Thank you so much. Over to you, Dr. Naveen.
Thank you very much, Dr. Tanuja. Yes. So before moving to the question and answer session, I would like to, I'm very glad to inform you, sir, more than 500 doctors have already joined, and they are in this program. So they are already joined, more than 500 doctors. Today we have a lot of questions, sir. So definitely, I'm sure, sir, you are ready to answer the questions. Doctors are participants are very eager to ask these questions. So let's take sir questions. I think I should stop the screen. That will be better. Yes, sir. So the questions are like this. The first question is like genetic or family history. Can it play a role in forming of kidney stone?
Yes, genetic and family history both play important role in the renal stone. These patients, there is inherent metabolic abnormality runs in their family and genetic history that may lead to the formation of stone, and this is commonly associated with the recurrent stone former patient.
Okay. This is very common question, sir, because many of times in the genetic history, when we are talking diabetes and all such conditions, metabolic conditions, here when in the stone, it is not discussed a lot.
There are many metabolic abnormality that runs in the family, and these patients are associated with recurrent stone formation.
Yes, sir. Now, second, very common question is coming, like it is already asked by some question, some of the doctors, like what are the dietary recommendations to prevent recurrence? Because recurrence is again a big challenge, sir.
Usually take 3 to 4 liters of fluid per day and avoid the oxalate-rich food like palak, tomato, chocolate, coffee, and take plenty of citrus fluid. Take regular exercise, avoid non-veg diet, which also these patients are more prone to stone former like purine and cystine stone. These are commonly associated with non-veg diet. So take the plenty of fluid, 3 to 4 liter, avoid oxalate-rich diet, regular exercise, and obesity is also associated with the recurrent stone formation.
Okay, sir. Thank you very much, sir. Now, next question is like how to proceed in case of 20 mm renal pelvic stone along with multiple renal cysts.
In 20 mm, in latest technique, we usually do the RIRS. In RIRS, we do the retrograde intrarenal surgery, in which we place the flexible ureteroscope per urethra and reach up to the stone and fragment it with the laser and remove the stone, lace the stone and remove the stone and pick. The stone burden is slightly more, but we put the DJ stent, and later on in second sitting we usually check the stone that there is any residual stone is left, or we can do the PCNL. If patient want complete treatment in one sitting, then we can do the PCNL very easily. Cyst does not interfere with the treatment of the renal stone, so we can easily do the RIRS for the latest technique and PCNL for the complete treatment in single sitting. So both treatment are easily available.
Thank you, sir. Thank you. The next question is like, what are the common conditions for nephrectomies?
Most common indication nephrectomy is chronic obstruction and non-functioning of the kidney. Patient come with the paper thin parenchyma, long-term stone in ureter, kidney is not functioning, large hydronephrotic or large pyelonephrotic. These are the common condition. We put the PCN tube and see the how much output is coming, or can do the renal scan. If there is no function, we do the nephrectomy. In hydronephrotic kidney, we can easily do the laparoscopic nephrectomy. But if there is pyonephrosis and associated adhesion, then we can do the open nephrectomy. So the main reason of non-function is chronic obstruction due to the stone disease and ignorance of the patient that may lead to the thinning of renal parenchyma and non-functioning of the kidney. That is the common reason.
Okay. Now, second, one more question is there. Is LASIK surgery safe for the kidney or not?
Yes. Laser surgery is very safe. Basically, earlier people think the laser surgery means ESWL, means lithotripsy. Lithotripsy is not laser surgery. Laser surgery is the RIS, retrograde intrarenal surgery, in which we reach the stone by the retrograde approach, reach up to the stone, completely see it, and then fragment it and completely remove the stone and put the DJ stent. This is this process we do under complete visualization. Like open surgery, we see the through the camera into the kidney ureter and do not injure the any system. If there is ureter is narrowing, ureter is commonly narrow, so we put the DJ stent, but it is very safe. We can easily remove the stone, but the limitation is that we can remove up to the it is safe to remove up to the 1.5 to 2 centimeter stone. If we can try to remove bigger stone, we will do the procedure for the longer duration, and that may lead to the complication like stricture formation or urinoma or injury to the system. So clearly select the cases. Small size stone up to 15 mm, we can easily do the laser surgery. And do in the morning and can discharge the patient in evening. It is very safe surgery and highly recommended.
Okay, sir.
Because there is no parenchyma damage.
Yes. There is another question. I think this question is for Himalaya. Along with allopathic medicines, can Cystone be given for a longer duration? Yes, of course. You can give the Cystone 4 Cystone along with the allopathic medicines. Sir, there is another question for you. Stone more than 12 mm can be crushed or not?
Crushed means
yes, without surgery.
Understand what I mean by crushed.
Without surgery, sir. I think he is without surgery can be dissolved.
Depend on the site and location of the stone. If it is in inferior calyx, it is not able to possible to remove pass out these stone easily. But if it is an upper ureter or upper calyx, that can be pass out. But 12 mm stone slightly difficult. There is very low chance, near about 5 to 10% chance these stone pass. But
yes,
not 70 to 80% these stone not pass. We usually say up to the 10 mm stone can be easily passed out.
Okay. There is another question is related to this question only, sir. Up to 12 mm is asking that Cystone 4 can be given. Yes, of course, we can give Cystone 4 up to 12 mm. We have the studies. Dr. Tanuja already discussed about the study, and we can give up to the 12 mm of stones. Yes. Another question is in case of ureterorenal calculus where there is hydronephrosis, how much liter of water can be consumed in 24 hours, sir?
Same depends on the size of a stone. If the size of a stone is bigger, more than 12 mm, it causing the moderate to severe hydronephrosis, then you should go for the definitive treatment. These stones usually do not pass out, and we can recommend for 15 to 20 days that you take plenty of fluid and check the x-ray or other finding where is the stone situated. If it does not move, it is unlikely to pass. If there is no massive hydronephrosis or moderate hydronephrosis, you can take the plenty of fluid. If there is no hydronephrosis or hydronephrosis is not increasing, then we can recommend the plenty of fluid.
Okay.
In each patient.
Sir, one more very common, this is question from my side, sir. It's a very common, like many of times, it happens like discussions. In some of the geographical areas, the stone forming is very common. Like if you see in the Rajasthan also, I think.
Yes.
So if you have any message for the doctors, what are the recommendations they can give to their patients, because already you have discussed like genetic history is also playing that role. So if they have a genetic history and they are from such a geographical area, what should they, take care for? This?
Only recommendation is take plenty of fluid as much as possible, because in Rajasthan, Western Rajasthan, there is lack of water, dehydration, very hot and humid environment. There is dehydration that lead to the crystalluria and formation of the stone. So take the plenty of fluid as much as possible, 3 to 4 liter at least per day to prevent the stone.
And sir, hard water also. Many of
Yes.
times they ask like
Yes,
hard water
with the stone. In these area, usually patient come with the large stone burden. Many stone, complete staghorn stone filling the complete kidney. So these patients should take the plenty of fluid and go to the nearest urology as early as possible prior to the damage to the kidney.
because early diagnosis is very important because
To prevent
I'm
the
sure you must have some experience, sir, when the patients are coming in the later stage.
stone is usually bigger size in these patient.
Okay, they are coming in the very later stages.
Yes.
So thank you very much, sir. I think almost the questions have completed here.
Thank you.
Thank you very much, sir. So once again,
Was doing such
really it was a wonderful discussion, sir, with you and interaction with you. I'm sure all the doctors have got a maximum benefit from this session. So thank you very much, sir. Once again, if any take-home message for all the doctors, sir. Final.
to prevent the complete take the plenty of fluid, advise your patient dietary advice to prevent the recurrence of the stone, and detect the earliest possible complication like infection, decreased renal function or renal failure, and give the as early as treatment to prevent damage to the kidney or nephrotic loss, so the patient not go on to the renal failure and required hemodialysis or nephrectomy.
Thank you very much, sir. Thanks
Plenty
a
of-
lot, sir. Thanks a lot. Thank you very much, sir. Thank you.
Thank you.
Now it's a time for final vote of thanks, and yes. So here I would like to invite Mr. Sival Jain, sir, who is a sales manager in Zenith division. He is again from Jaipur, sir, from your city only. So I requesting Sival, sir, please, sir, come and give a vote of thanks, sir.
ये क्या उस दिन आए थे वो है क्या साहब?
Yes, sir. Yes, sir. शिवाल सर अनम्यूट करना पड़ेगा. Yes, sir. Please unmute, sir.
Boss, he is trying. Actually, it is not happening from their side.
एक बार waiting for a few seconds.
Due to some technical glitch, actually.
No issues. So, sir, as a vote of thanks, sir, yes, on behalf of Team Himalaya, I would like to thank you, sir, for your wonderful presentation and the case studies which you discuss. Like it is really all the doctors have got the maximum benefit from them. And special thanks to all the doctors on board for your valuable presence, support, and patronage. On behalf of Team Scientific Services, let me thank all Himalayans who joined hands together to organize this event. My deepest sense of gratitude and appreciation to all those who made this event a resounding success. Once again, thank you very much, sir. Thanks a lot. Jai Hind. Thank you. Namaste, sir.
Really.
Thank you, sir.
Thank you so much, sir.
Thank you, madam.